about the fate of the aortic root and pulmonary bifurcation late after the arterial switch operation. And I have to say that I very much thank the group around Professor Kramer, who is leading the pediatric cardiology now in Kiel, and especially for Dr. Rickers for providing me with the data, especially the 4D MRI data, what I like to show you. And I will not forget to thank very much Mrs. Traute Hansen, who is the master of data management, who helped me so much to get together all these data. Thank you very much. So I think all who like to treat or who treat patients like to come near normal, because I think that the paradigm that normal anatomy and physiology is the optimal solution. It is nothing better than normal or autologous. And the surgery with TGA has done a lot of success because most patients at birth are prone to death. And by surgery, they come in the area of normal children. And then it follows the area of growth. And the growth area has the possibility and the risk of a great impact of surgery on morphology. And afterwards, it is more or less aging. And the question is, how near can we come to normal? I think it is clear that we cannot come to normal with all congenital pathologies, but we should try to come near normal. And therefore, the follow-up is very important. And one especially stage in follow-up is the end of growth, the beginning of aging. This is a point where we have to look very carefully to see what growth has done with our procedures. And this is what I want to talk about at this area. Now, look here, I think probably all of you know, this is a normal heart, this is what we want to achieve. And you can clearly see that there are not only great vessels, the pulmonary artery a little bit to the left of the aorta, but there are also nerves, and I forgot the lymph nodes and all these things, and these are transected by the transposition. We have to know that. This is a picture showing the pulmonary artery a little bit to the left, and a very important thing is the main coronary artery, the left main coronary artery here, running behind the pulmonary artery. And I will come back to this area here. I think is a very critical area in the arterial switch operation. So what is also of great importance is the spiral flow. And here the group of Kilner, I think it were the first to show that there is a spiral flow in the heart. And this holds also true for the atrial, but I'll only show to you the arterial connections, the great arteries, and you can easily see that there is a very intelligent spiral flow in the great arteries. So this is a 4D MRI with the flow showing the spiral relationship of the pulmonary artery and the aorta, and there is almost no red color showing that the flow is laminar in this area here. This is, nothing is better than this. Okay, this is TGA. You all know this picture. This is the common form with the left coronary artery and the pulmonary artery a little bit to the right, aortic root a little bit to the right, pulmonary artery in the left. I think you everybody know we're talking about. And we have heard tomorrow very interesting things about the developmental aspects and the genes related or involved in the development of transposition. The neural crest cells are not involved. If you cut the neural crest cells, you don't get a transposition. But I think I was very impressed when I read that somebody think that maybe that is true, that the TGA is arrested rotation of the myocardial wall of the outflow tract. We will come back to this later. So I will come now to the operative techniques, serial switch operation 1 or 2 stage. And you know this is more historical. It's a 2-stage with a Dacron tube on the left or reductant group on the right, published by Mekdi Yacoub, that this is a risk for pulmonary stenosis. And then the current technique, the Lecomte technique, which was introduced because of the problems with the prosthetic conduit, published in 1981. Prosthetic conduit. So I show you, first of all, a picture or a patient with a two-stage procedure, born in 1983, Reshkin, bending, Bilow-Taussig, switch, Dacron tube. On the left side, patch-plasty suprapulmonary stenosis, homograph, right ventricular outflow tract patch, homograph replacement by bioprosthesis in the last year. So 5 cardiac operations at the age 28, and this is not the end of the story, because the bioprosthesis will degenerate later, earlier or later. So this is the fate of a patient, age 20 years of age. And this is his angiogram, showing the big aortic root after the bending procedure, usually to be seen, and the conduit stenosis in the pulmonary artery. So this is more historical, but what do we have for results, or what for results do we have with the Lecomte technique? And this is a presentation, I think it was last year, done by Dr. Rickers, again from the Kiel group, and he investigated the patient's one-stage arterial switch operation in relation to the size of the different diameters with MRI studies, and he could show that the aortic root, even after one-stage switch, is significantly enlarged to control, not the ascending aorta, not the descending aortic isthmus, and there was a steeper arch angle, significantly steeper, and the aortic regurgitation was higher. The left ventricular function was okay, no difference from control, and the left ventricular mass was increased. I do not go through the data from the two-stage because I think this is more or less historical. So they also investigated the distensibility of the different parts, and you can see that the aortic root has a threefold decreased distensibility compared to normal. That holds true also for the ascending aorta and the descending aorta. There was no increase in pulse wave velocity, but in the two-stage patient, there is an increase in pulse wave velocity. And what is interesting to be seen is that there was a positive or a significant relation between distensibility and the age of the patient after arterial switch operation. That means that with increasing age after the operation, the distensibility is decreasing in the ascending aorta. And remember, the normals are in the area of 9, and this is already 2 after 30 years, which cannot be found in controls after 30 years. So it seems to be that the aging process is a little bit accelerated in these patients. This holds also true for the pulse wave velocity, as shown here. So I show you some pictures from the Lecomte procedure, and this is a publication from Agnoletti showing that the normal arch here, comparison to a Lecomte patient with the indentation of the pulmonary bifurcation here. And he concluded, or the group concluded, that the sharp angulation of the aortic arch is associated with early pulse wave reflection, dilatation of the ascending aorta, and aortic regurgitation late after arterial switch operation. And probably this also has a little bit to do with what Professor Alexi said, that it might be a premature degeneration of the leaflets of the cusp after the switch operation in the aortic root. So what about the function? So we can see that in this big study here with a large number of patients, most patients after 20 years are free of aortic regurgitation grade 1, roughly 70%, but 30% have some kind more of aortic regurgitation, and the hazard is a little bit increasing over the years. What about the reoperations? Aortic regurgitation is relatively free after 20 years. However, the hazard function is increasing in this time schedule. So when I put it together, we can say for the aortic root, this is significantly larger than normal, the root diameter, but relatively stable over time. The ascending aorta not larger than normal, arch angle steeper, distensibility reduced, and left ventricular mass increased. So the question is why? If we don't understand why, we cannot improve. So is it denervation? It was from Dr. Pretre also touched. You can see here a picture that the pulmonary trunk and the aorta are innervated, especially the vasa vasorum with sympathetic nerves. There is some kind of re-innervation shown by MIBG imaging, but it's more or less related to the left ventricle. We do not know. Is there a re-innervation of the arteries? The next point, is it the damaging of the vasa vasorum if we cut the great arteries? Yes, there is a paper showing that in dogs, if you remove the vasa vasorum, you have a dramatic decrease of distensibility. But what about the revascularization of the great arteries? Is that possible? We don't know. The next problem is age. Is it probably age what makes this aortopathology? And we published several years ago that the aortic root is stiffer after arterial switch if the bending procedure is performed later in life. So maybe that age also plays a role, as was already shown, as I showed you in the slides before, as a premature aging process. Or is it shear stress? That's another very important point. And I show you here the 4D MRI in a patient with a slight dilatation of the ascending aorta, not more. But there is a great vortex here, and this vortex causes a lot of shear stress at the convexity. That is not the case in the normal ascending aorta. So this is after Lecombe, a similar big vortex in the ascending aorta just beneath the pulmonary bifurcation. So again, I am very thankful to Professor Rickers and the Kiel group for providing me with these data. So we find also in the ascending aorta big vortices that may have some consequences. The question is, does increased stiffness or flow disturbance of the ascending aorta or pulmonary artery matter anything? That's the question. Well, their interesting paper, they put an inelastic vascular prosthesis in a descending aorta, and they found that there was no increase or difference in resistance or pressure gradient or compliance. However, there was a great difference and increase in characteristic impedance. And they concluded that since there was no increase in arterial resistance, we conclude that the increase in pulsatile load, and that is characteristic impedance, was the cause of left ventricular hypertrophy. Because you can measure in dogs a significant increase in left ventricular hypertrophy if you replace the ascending or descending aorta. And there's another publication from Simon Kublik showing that a non-compliant prosthetic replacement and the compliance of the prosthesis is around 1 to 3%. It's similar to what we find in the ascending aorta as shown by Dr. Rickers. And he found that non-compliant prosthetic replacement of the ascending aorta is a risk factor for aortic root aneurysm development. And if you remember the presentation of Dr. Gittenberg about, I think maybe I have a slide showing that the area in the aortic root is a little bit weaker than normal. And there's another interesting publication showing that the wall stress, especially the oscillatory shear stress index, which is the time derivative of the normal shear stress, is pro-arteriosclerotic at different areas showing in white here. So shear stress has an influence on the development of the aortopathology. And furthermore, there's a paper showing that laminar shear stress stimulates vascular smooth muscle cell apoptosis via the ACT survival pathway. You know that the ACT gene is a survival gene, and this is a very interesting paper. And again, another paper showing a negative regulation of vascular smooth muscle cell migration by blood shear stress causing pathological events. So the shear stress is not negligible. Or is it tension? So if we reconnect the great arteries, maybe that there is occurring some tension. This paper shows that if you put a strip of the aortic wall or if you give to a strip of the aortic wall some transforming growth factor beta, you increase the activity of these different proteins here, smooth muscle actin, and transforming growth factor beta, heat shock protein, and so forth. But if you put additional tension on this strip, you dramatically increase these fibrotic activity proteins. So the question is, does tension induce fibrotic activity? And after these experiments, yes. Or is it a genetic dysregulation of mechanotransduction? So this is an absolute interesting figure, and showing that mechanotransduction, or a crosstalk of cells to force, may have a dramatic influence in the development, and the bloodstreams, in the tube during development, or even during the adaptation process. And I will not go through all these figures, but showing that the stress on the endothelial cells are reacted to in the difference to this, the force that is applied. This is cyclic stretch with non-conformational changes, and this is static stress has a different other changes in the proteins of the wall. I think mechanotransduction will become a great area of research in the future. Or is it a primary wall pathology? And now we are back with Professor Gittenberger de Groot. It's a paper of their group showing that the organization of cells in TGA, aorta, and pulmonary artery are less compared to the normal, and that the collagen distribution, or the amount of collagen in the arterial roots, is diminished in TGA, as showing in the blue color. Here is normal and there is TGA. So there is a weak constellation in the root and the great arteries. Or is it the surgical manipulation that we do, the bypass, adventitial scar? And again, I'm thankful for Dr. Rickers providing me with these data that had not been published to date, and showing that the comparison between the arterial switch operation and patients with ascending and mustard show both a reduced distensibility, the Denbachkeit here, of the aortic root and ascending aorta, and also a decreased or increased pulse wave velocity in both groups. So the reduced distensibility seems to be less related to direct surgical approach. But what about the scar formation at the great arteries by merely open the chest? Why is after mustard, where we do nothing at the great arteries, the distensibility is decreased? So in summary, I would state that probably the pathology of the ascending aorta is related to both genetics and environment, as usual in the life. This is the law of life, genetics and environment. And surgery, environment is surgery, and the physiological sequelae like flow disturbance. So let me come shortly to the LECOM results, showing that the pulmonary annulus and the pulmonary sinus are reduced in size and growth, as shown again by the Kramer group. This is a flow showing the accelerated flow at the bifurcation of the pulmonary artery here. This is a 4D MRI of an, I think it's a good LECOM operation. However, there's an increase of flow acceleration, of flow velocity, where the left and the right pulmonary arteries cross the ascending aorta, and you can see the steep angle of the ascending aorta. And again, this is an excellent LECOM. You see almost not or no, very little acceleration of flow at this area here, but it is not zero, as you can see. And if you look at the pulmonary artery, it is a little bit lower in the diameter than the aorta. So, but there are pictures, they are not so good. And this is a presentation from Good-Berlet showing that there is a dynamic compression of the right pulmonary artery when it crosses the ascending aorta in systole and diastole here, systole here. And I show you a picture with the indentation of the bifurcation after the LECOM with a steep angle, and this looks like a cramp compressing the ascending aorta to the back. And even more, it can create, or it can occur, a big aneurysm of the root, showing here. After they come, here's the bifurcation. And models of flow velocity have shown that the Lecombe technique shows increased flow velocity at the bifurcation and root, and also the pressure contour is pathological in this technique. They concluded that there is a disturbed flow for Lecombe model and that is a pressure energy loss. This is substantial. And has it consequences? Maybe. There is the first publication showing that the right ventricular hypertrophy and diastolic dysfunction in arterial switch patient without pulmonary stenosis. It may be related, what I have told you, to the characteristic impedance that you cannot measure directly. And there's not only a not measurable influence on the right ventricle, but also a significant stenosis in the pulmonary artery that needs reoperation. That's the Bentalune and the button technique, but both have some kind of risk for reoperation, and the conduit is more historical. So I put together, there's an excellent option, there's a Lecombe technique in a lot of cases, but no physiological arrangement of the great arteries, leading more or less to flow disturbance. Right pulmonary artery is in the direction of the aortic curvature. There's an energy loss. There's some kind of pressure gradient, right ventricular hypertrophy, diastolic dysfunction, probably related to or induced the aortic root dilatation, maybe, and steep aortic angulation. What are the long-term sequelae? We don't know. Now we have 20 years, and I'm very interested what happens the next 20 years. So are there alternatives? And I will stop in 5 minutes. I will not like to bore you. Are there alternatives? That is restoring the spiral flow as created by Shiu. I must say I have read this paper several times and it was difficult for me to follow what he did. And the reoperation rate, I think this for the pulmonary artery is not better than for the non-spinal, for the Lecombe technique. So let's remember the first successful arterial switch operation ever performed was by Yaten, 1975, published in a Brazilian paper, and he did transection of both arteries and did a spiral connection. So what I like to present you, and this is why I'm here, we have done 20 years ago 4 cases, and we mobilized the arch vessels a little bit more to get more length of the ascending aorta when transected, mobilize both pulmonary arteries, and of course the area of the ductus arteriosus. So this is the first case. Look here, no normal arch angle, pulmonary artery on the left. It looks like that the pulmonary artery has some kind of redirection to the left side. Very, very interesting picture. And we have a coronary angiogram here. Look at the left coronary artery. This is the right coronary artery, is no problem. The left coronary artery, no compression. Even if there is a redirection of the pulmonary root. That's the left coronary artery here. So this is, what's that? This is the next case showing that there is very laminar flow, spiral configuration. That's case number 2, there is it, case number 2, 20 years after this procedure, almost no disturbance of flow, blue color. And this is not a TGA, this is a normal case, also blue color, spiral flow. I think a great figures from MRI studies. This is the third case, spiral flow, MRI, 4D. No flow disturbance. Maybe here in the pulmonary root a little bit curvature. This is a figure to that. This is case number 4. Again, spiral flow, but there is a little, maybe it's a tech in the outflow tract. We are not quite sure. Or it is an aneurysm of the bottom that I used at those days, pericardium, or it's a tech in the outflow tract, but a spiral flow, no great disturbance. So let me put together. We have done 4 cases 20 years ago, and this is what is so important to wait until the growth period has happened and is completed. There are less vortices, more luminal flow and spiral flow, and some of these pictures were sent to Stanford University. They can quantify the vortex. This is called vorticity. And you can see that it is 20% less vorticity in the direct spiral anastomosis compared to LeCombe, both for the aorta and the pulmonary artery. We had no or only mild pulmonary stenosis. The greatest stenosis was 50 millimeters of mercury. There's a normal size or slightly enlarged aortic or pulmonary root. It's almost normal in all cases. There was a normal angle of the aortic arch. We had very low grades of regurgitation. I think one has a grade 1 only. There was, however, one coronary occlusion, but without scar and excellent collaterals from the right coronary artery. We made an angiography, and if you look into the right coronary artery at once, the LAD is colored. So this might have been a longer process and not an acute process. There is no scar, and all patients are in excellent condition. It was difficult to gather them together. There was one, I call it selective aneurysm of one pulmonary root button, but maybe it is an outflow tract myocardial tag. I'm not quite sure. There is, and this is a very interesting phenomenon. I'm not quite sure if it can really happen. Is it a redirection of outflow tract rotation? Can that occur, that during the growth in the babies, this arrested rotation of the outflow tract can be completed? And if you remember the pulmonary arteries, they are on the normal side. And what about the mechanotransduction during growth as adaptation to spiral flow and tension? So the last slide, up to 20 years postoperatively, the status, the size, the routing, the biophysiological properties, especially of the LeCombe technique, after the LeCombe technique, of the aorta and pulmonary arteries are not normal. This may be related to genetic, of course, we have heard it tomorrow, defects, and surgical intervention. Surgery is not simple and not normal. The question is, what is going on with these children or these now adults in the next 20 years? Careful follow-up is necessary, and the question is, can we improve? Is it possible? And I do not like to convince anybody to do the DSA, but is it possible in some cases, with special attention to the left coronary artery? I showed you this figure in the beginning that I think the left coronary artery is for this re-rotating the crucial point. Is it possible to do a DCA in some patients, or I'm not quite sure why the pulmonary artery rotated. Is it a tension or stretch on the pulmonary artery? Is it possible to implement or to put in the pulmonary artery maybe 1 or 2 centimeters of extension during a tissue-engineered tube to reduce tension, which is an experimental program now in our clinic. I thank you very much for your